All right, thank you everyone for joining us today, or if you're watching this recorded, thank you for taking the time to join us today to learn about what newborn screening advisory boards are and how they can actually be your greatest ally in seeing your condition of interest added in a state. Before we begin, I wanted to quickly share from my personal experience to give some context about the discussion that we're about to have, because I know firsthand how intimidating it can be to approach an advisory board, and I know what questions you may have. So first, for those who don't know, my daughter Victoria had Krabbe disease, and she died at 20 months of age in March of 2016. I attended my first Pennsylvania Newborn Screening Advisory Board meeting 3 weeks after Tori died in hopes of convincing them to begin screening for Krabbe. Instead, I left that meeting feeling as though the board was not only against screening for the disease that had just taken my daughter's life, but also against me. And I felt that the chair of the board, who is actually one of the panelists today, was my adversary. Thankfully, I was wrong on all accounts, but it took me a while to learn that. So I want to help you learn that before you might begin this journey. In the years since, I have attended every meeting except for one, and I have come to respect and support newborn screening advisory boards and the role that they play in newborn screening. I realize now that we as parents and advocates need to listen to understand them and to see where the advisory boards are coming from. Because while we see things differently, that doesn't make us enemies. In fact, together we can accomplish great things, and our voice as parents matters. I am actually now a parent advocate on the lysosomal storage disorder subcommittee of the advisory board, and I am continually seeking to learn the best way to add conditions. Though it is tempting to add conditions legislatively, 47 states actually have newborn screening advisory boards, and we at LDNBS encourage our advocates to take this route instead. I'm now going to have each of our panelists give a brief intro so that we can get to know them before we dive in. Each of our guests today are or have been on a newborn screening advisory board, and each bring very different experiences to the table. So starting with Dr. Vockley, can you each share a little bit about yourselves, your experience, what state you were from, how long you've been involved with an advisory board, or anything else you'd like to share?
Thank you, Lisa, and I'm sorry. That's all I can say. I was that person who she hated for a while, but we learned to work together, and we got a lot more done together than we would have individually. So I think we both learned some good lessons, and I really didn't ever consider you an adversary. I'm Jerry Vockley, and I'm the chief of genetic and genomic medicine in Pittsburgh, and also direct a program called the Center for Rare Disease Therapy. And I've been involved in newborn screening for a long time. Before I came to Pittsburgh, which was 19 years ago now, I was at the Mayo Clinic in Minnesota, and I was on the newborn screening board there for 8 or 10 years before I moved here and joined the board, and can't seem to quite get off of it. I was chair for a number of those years. Now I'm happy to let others drive and try to help with my experience. I was also on the committee that curates the RUS for HRSA, so have that experience as well. And as a newborn screening follow-up metabolic center here in Pittsburgh, I also take care of the kids that we diagnose. So it's I consider it full service, and it's easily the most important thing I do in my life.
Thank you so much for joining us, Dr. Vockley. Amy, would you like to go next?
Sure. Thanks, Lisa. Hi, everyone. I'm Amy Gaviglio. I am a genetic counselor by training, and currently run my own consulting company called Kinetics Consulting, where I provide services to a number of national organizations working on newborn screening and rare disease, genetics, genomics, public health issues. So my career and kind of experience in newborn screening advisory councils started when I was at the Minnesota Newborn Screening Program. I was there for 12 years. I was their follow-up coordinator, and really regularly participated in and presented at our Newborn Screening Advisory Council meetings. Currently, I assist some of the other advisory councils through the state on specific projects. I'm also currently the chair of our Rare Disease Advisory Council, which is another really important advisory council for advocates to learn about and get involved in. We can talk about that maybe a little more later, but also on the education and training work group for the Federal Advisory Committee as well, and really echo what Lisa said about how important and helpful it is, not only for, I think, advocates to come to these meetings, but for the council members as well, to really hear from advocates who, quite frankly, bring an expertise that many of us don't have, and that's that lived experience. So very excited to be here and talk more about this today.
Thank you, Amy. Bob, would you like to go next?
We're not hearing you, Bob.
Are you able to hear me now?
Yes.
Okay. I think my headphones might have been causing a problem. So good. I'm Bob Rauner. I'm the president of the United Leukodystrophy Foundation. So I've been involved with the leukodystrophies for a number of years. Our son Kevin was diagnosed with adrenal leukodystrophy back in 1993. And so I've been involved in this space for a long time. I'm one of the antiques around. So I think Jerry could probably understand we have a similar age, probably issues as well. So, but it's been fun. I'm in the state of Nebraska. I live in the capital, Lincoln, Nebraska. I really got involved. ALD was finally added to the RUSP, and in 2015 is when I started working and learning what I needed to do to get ALD added to the screening panel. So I know I can talk a lot more about that as the day goes on, because I know we're on time, and there's some things that I definitely want to share, but I know we want to keep this thing moving as quickly as possible. My other involvement in 2018, we started the process to add CTX to the panel. So we were in front of the committee and we were denied at that point in time, but there are efforts now to I think we're meeting some of the goals that they recommended. So I look for that to be coming up rather soon. So I'm glad and happy to be on this panel, and hopefully some of the information that I can share will be good information that you can use in the future. So thanks, Lisa.
Thank you, Bob. All right, Carol, your turn.
Okay, I'm Carol Cross. I'm from Iowa, and I've been on our Congenital and Inherited Disorders Advisory Committee in Iowa for about 2 years now. I was recently appointed to the subcommittee for the management of our newborn screening panel, which just is forming due to our RESP alignment legislation that just passed this year. I worked with Every Life Foundation and some other parent advocates to get that bill passed. We're really excited about the passing of the bill. I'm the mom of 2 children with Krabbe disease. Our son Joshua passed away in 1995 when he was 2.5. And our youngest daughter, Laura, was born with the disease as well and was transplanted when she was 19 days old. And she just turned 23 this year. So thanks for having me. I'm really happy to be here.
Thank you all so much. So the first question I want to ask you all, because you all come from different states, and as we all know, every state does everything very differently. I would love to know a little bit about how the advisory board functions in your state. Like what is it responsible for? What authority does it have? Anything along those lines, but also why you think advisory boards are important.
Well,
So whoever would like to go first.
I'm happy to dive in. I can tell you, I think that in Pennsylvania, our advisory board is responsible for everything that makes parents happy and mad, and has none of the responsibility or none of the authority to do anything. At least it used to be. That's actually fortunately changed in large part because of work through Lesa. In Pennsylvania, the board is appointed by the state health commissioner or the state health director, and it consists of anywhere between 15 and 17 individuals across the diseases, specialists across the diseases that are screened, including and includes parents and patient advocates, hospital representation. So it's a broad base. My somewhat flippant introduction to this comment is because we don't actually put anything on the screening panel. We make recommendations. For many years, those recommendations really were not acted on in any real regular way. It was up to the whim of the health commissioner to decide on whether or not he or she wanted to follow us. And more recently, we had a landmark bill passed that said the Secretary of Health had to listen to us. More importantly, that we, the board, actually had to listen to the RUSP. So if it got on the RUSP, we had a chance to look at it, but we were obliged to pass that on. In my time on the board, we've increased the number of diseases in Pennsylvania that are screened from 6 now to the maximum. It depends on how you count them. It's somewhere between 30 and 50. Everybody counts them a little bit differently, but we're all doing the same tests. As a middleman, if you will, between parents asking and health authorities in a state providing, that's our position.
I can go next. We can just go in the order of introductions, maybe to make it easier. But so yeah, I would say Minnesota is very similar kind of setup as what Dr. Vockley just mentioned. So our advisory board is set in statute as well, consisting of a certain makeup of individuals. And I will point out that when you look at our statute and the list of kind of representative groups that need to be included, the first group are parents and other consumers. And I always like to point that out because I again think that that's just such a pivotal component of advisory committees, whether you're on the meeting or on the council yourself, or you're just joining the meeting. In terms of adding diseases, that is, of course, a big function for the advisory committee in Minnesota as well. And similarly to what Dr. Vockley mentioned in Pennsylvania, they are not also adding conditions per se, but making that recommendation to the commissioner of health to add those conditions. It is the commissioner who ultimately has the authority to say yes or no, or essentially accept the recommendation of the advisory committee. I know that much of the focus of probably today's discussion and many advocates kind of interest in advisory committees is around adding new conditions, but I think there's some really important, interesting roles for advisory committees outside of that as well. So, maybe once a disease is added, providing guidance on what implementation looks like and making sure that the families have, as seamless of an experience as possible, looking back at the conditions that we've already added and making sure we're doing our screening and follow-up in the best possible way, looking at our performance metrics. For us, I as an employee of the newborn screening program, really relied heavily on the advisory committee to help us think through maybe different projects we were going to work on, or if hot topics came up in terms of dried blood spot use or genetic privacy, pulling in those experts and getting unique perspectives is another, I think, really important role for advisory committees as well.
All right, I guess I'm next, so I'll try and run through the sweep real quickly. We in Nebraska are very similar to what's been talked about. Our committee is set up by statutes. It includes medical personnel as well as patient advocacy members. And usually if a new disease is added to the RUSP, someone from that disease group is invited to participate in meetings, which is really good. Our state statutes, I think our committee's job is to make the recommendations, and they really do a great job of background and making sure they understand the disease before it's added. So in Nebraska, treatments are a necessary thing before diseases get added. We're a small state. We don't have a lot of people to collect money from, so we're limited on what we can and can't do that way. But it's really, you know, when we make recommendations to the Health and Human Services, they typically make the recommendations. Now, that said, some of us parents, if we aren't getting the results, then we go legislatively and create some bills that will bring these diseases on board. So sometimes our health department is tied by budgets, so that's a big challenge. And back in 2017, when we actually added ALD, MPS 1, and Pompe disease, I had to fight the battle, and we ended up finding a way to create the funding, which was needed, and so that ended up working well. So a funding mechanism is always a good, positive way to do it. So that's really, really important from my perspective. So, but it's, I always tell families, don't be afraid to go and look in, take some legislative action. And I think, you know, this group can probably be very helpful going forward. And we'll probably talk a little bit more about that here a little bit later. So I'll move it on to the next person.
I think that's me. I was very similar. Our advisory committee makes the recommendations. We recently have had kind of two changes in Iowa, our restructuring. So our Iowa Department of Public Health and our Department of Human Services, we used to have two, now they've converged to one. So a lot of restructuring is taking place. So we're still kind of looking at the fallout of that. Also because of the RUSP alignment legislation that was just passed this spring, that's kind of changing things in our advisory committee as well. And thus the forming of this subcommittee, which is actually going to be the committee that is going to be exploring the diseases that are the disorders that are being added to the RUSP. So we're getting ready to do MPS 2, which was just added. And then we're going to be making the recommendation to side act to our main advisory committee. So pretty similar to the way the other states work.
Thank you all for that insight. It does sound like at least these four states function very similarly, but I also want to highlight some differences that might exist. So last week at the APHL Newborn Screening Symposium, a woman named Elizabeth Bear from South Carolina was sharing their experience, and she made this comment that really stuck with me. She said, the fact that we all do things so differently puts us at a disadvantage. So I would love to ask all of you, because you all have vast newborn screening experience, whether from your own personal journey or from professional life, what would you like to see change in the way that everybody does things so differently? And if you don't have an answer, that's okay, but I feel like this could be a good point of discussion.
I'll dive in first again. I'm not shy. You know, the problem is I think this comes down to in many ways, whether you're a big government or a small government advocate. We have 50 states, we have 50 newborn screening programs, and we have one group, the HRSA Secretary's Advisory Committee that's curating the RUSP. How about if we have newborn screening implementation committees and just listen to the RUSP? They've done a ton of work on all of these disorders, and if a recommendation to screen comes down from the RUSP, far be it from me to say, I disagree with it. And in fact, our legislation now mandates that we can't. So why do we even need that function? So I'm in favor of a national mandated screening instead of recommended screening. I think that where we run into trouble with that is that sometimes it feels more daunting to approach a national infrastructure and try to change it than it does your local state. And so I'd be interested to hear how other people feel about losing some of the autonomy that you might have locally in favor of maybe some increased efficiency and being able to focus dollars into implementation and maybe even therapy rather than deciding about the conditions.
Yeah, I think that's an interesting point. I do kind of like the concept of implementation committees, and I will say that I know my colleagues in the newborn screening community are probably really sick of me saying the word harmonization, but that is my new buzzword and probably will be for the foreseeable future until we start to see a little bit more. I definitely agree with what Beth said. You know, there's the saying of you've seen one newborn screening program, you've seen one newborn screening program, and that it is very difficult when things are done so differently. It's difficult in a number of ways, from advocates having to understand all of these different processes that they have to go through. It's difficult for us to even combine our data and learn from each other, and really understand what health outcomes are. So I'm a big proponent for trying to figure out ways to harmonize. I do think a big portion of it does come down to the disparities in funding between states, and that's just really difficult. Newborn screening is not in a vacuum. We're part of a very poorly resourced public health infrastructure in the United States, and some states are better served than others. So yeah, I would like to see ways for us to try to harmonize, maybe to use some regionalization approaches, to kind of take some of the burden off of states who maybe don't have the infrastructure, give them a little breathing room while still being able to screen babies. That's always, I think, our end goal. We want the babies screened. Who's doing the screening? I think people care less about. So if there's ways to give programs just a little breathing room, take some of the burden off, still get that done, I think that would be an interesting kind of way to start approaching some of the variation that we're seeing.
I really agree with you about focusing on regions. In Iowa, we also screen for South Dakota, North Dakota, and Alaska, which kind of far away, but
not super regional.
but we in that sense, though, that we are kind of joining together with 3 other states for our program. And I'm hearing, and I didn't realize this, that some of the other states, like South Dakota, has started influencing Iowa's decisions about screening because they want something. So Iowa's saying, okay, we'll do that. So kind of a mutually beneficial situation, I think. But I do think that joining kind of together with some other states, especially those of us that are smaller, is a really great idea. But I think what may work in a state like New York isn't going to work probably in a state like Iowa. So I think that some differences are not necessarily bad. But I do think also that the funding disparity is really a problem. And I wonder if that's something that might be really helped if we had some kind of federal program. In the same way the federal government helps states and other things. I mean, we kind of we've seen this through COVID, that, there's a way that the federal government can help. I wish that was present somehow. I don't know all the details, or I don't really know how that would work, but I wish there was something like that. I also agree about the idea that the RUSP should be a mandate, that I don't think it should just be a recommendation. And it's almost like we're trying to reinvent the wheel. Like, why are we reviewing all this data? Why, this committee of people with incredible expertise and understanding. They've done it already. So why are we reinventing that wheel? So that's a kind of a frustration to me, that why are we spending all these resources and time to do something that's already been done very effectively? Yeah. Sorry, that was my soapbox.
And Lisa, if I
And
can
share your
add-
soapbox.
you're absolutely right. You're preaching to the choir on this set of open windows. I want to add one more thing here to the mix, because I think it's important to note that the technology for newborn screening is about to change. We're at an inflection point, right? We moved from single tests to identify one disease to a test that could identify a whole bunch of diseases. We're now back to single tests, but that's going to all go away, because molecular technology, the ability to sequence the DNA, all of the genes for every baby, now exists. And it's pretty soon going to be cheap enough to do it on every baby. And it's going to blow our paradigm out of the water, one disease at a time. I don't think so. When you can now identify, depends on how you define it, somewhere between 500 and 1,500 disorders that affect newborns. We're going to have to come to grips with that, and it is going to hit small states, rural states, states without a major footprint in molecular technology much harder than it hits the rest of the folks who have been there and are doing sort of those sorts of things in pilot programs now. So I think it's important to have the conversation about, what's the next 5 years look like, but beyond that, it's going to be very, very different.
I would kind of jumping right into what you were talking about right there. The other problem we have, that there's only like two diseases that get added per year, and we've got technology to add more diseases. So that's really important. So if you might spend 2 years trying to get to the RUSP, and then you have to go through another year's worth of investigative work, and then they'll finally bring it there. So it's, is there a way that we can run more diseases through the panel? What can we do? That said, the work that's done to actually get your disease approved, there's a lot of work that goes in the background, and the panel does a great job of really making sure that everything is done properly, so they're in the process of protecting everyone as well, because we don't want a program that creates problems. We want something that's good, solid evidence, and we can improve that. Just a kind of little note, I didn't mention this earlier, but like Nebraska state is up to date. We screen for all diseases that are added to the RUSP. So at least I feel good about our state being progressive and doing that. And I feel like I helped that along over the time so I've been a part of adding 4 different diseases, and now that I'm curious to watch how our MPS 2 runs through. That'll be coming up this year, so we'll get that added at some point this year. National level, we do need something from the Fed help. Lisa Seeger's been working for years at the federal level trying to get funding to support diseases that are added. ALD is a perfect example. When it was added, it's probably been almost 10 years ago, and we've still got about 30 states that aren't screening for it. That's a slow process, and that's something that, your zip code determines whether you get your child checked for XALD. So, and I think pretty much, Bombay and MPS 1, I think there's a lot of similarities there as well. So to be totally honest, I think SMA was the fastest one to get through the whole system. So that's kind of my 2 bits. And I'm thinking let's change the name from recommended panel and do it. And then you have to find a way to do the funding. And I think that's probably our largest challenge that we have going forward. So.
I mean, these discussions are super interesting, and as they pertain to advisory committees, because I think there's going to be an increased role of advisory committees to think through exactly, Jerry, what you mentioned in terms of increased technology using whole genome sequencing, whole exome sequencing. And not only that, but we expect to see a lot more gene therapies coming down that will make a lot more diseases appropriate for newborn screening. And thinking about that intersection of technology, therapy, and ethics, we are still mandating this program, and what does that mean? I think is going to be just very important and interesting discussions for advisory committees. I also think we need to think beyond funding. And again, I think parents and advocates have interesting thoughts on this, because there is congressional funding that goes to newborn screening programs. Part of our problem is that newborn screening programs are so poorly resourced, they don't have the people to apply for the funding. It's this like horrible catch-22. And so, or they get funding to hire people and they can't find people who want to work in public health. And so, I do think thinking about these different models, Carol brought up, the Iowa regionalization, can we start pooling some resources? I think we're going to have to start being super creative. And the more perspectives we can bring into these discussions, I think the better the solutions will be.
I totally agree with everything you all said, and I share your soapboxes. And what you just said, Amy, is a perfect segue into my next question. But first, if you are watching this and you have questions that you would like to ask, we will have some time for Q&A at the end. So go ahead and put your comments in the chat and we will make sure that we get to them. But Amy brought up the incoming gene therapies that are coming. And I feel like this is the perfect segue, because now I want to kind of shift to advice that we can give to advocates, whether their condition is on the RUSP or not. An example of a non-RUSP condition that is newborn screening ready is, or just about, we're waiting on Screen Plus to catch one, but metachromatic leukodystrophy has a gene therapy that we anticipate will be FDA approved in 2023, but it's only on a pilot program. So advocates are, ready to go, and because they know that the therapy's here, it works, it's about to be approved, but it's not on anybody's newborn screening panel except for Screen Plus, which is a very small pilot. So what would you recommend to advocates? It doesn't have to just be MLD. What would you recommend to advocates whose conditions are not on the RUSP about approaching an advisory board versus, I mean, you could also mention ones that are on the RUSP if the state's not screening for it.
I'm going to let the advocates go first this time.
Well, maybe I can just kind of tell what I did. When I started, fortunately, one of the doctors that's worked with our leukodystrophy patients as a whole, he was actually on the committee, so that was at least helpful. So I knew him. So what that allowed me to do, he kind of filled me in on what's going on. So what I did is I started attending the advisory committee meetings. I wanted to learn what they did. Plus, that gave me exposure to all of the different doctors. And in our case, the doctors come from clear across the state. So, I mean, we have rural communities, so you get that rural input, plus you have the larger city input, which is really, really key. But that way, everybody understands the challenges across the state. So I think that's good. But to me, that was the first thing I did. At our committee meetings, obviously, our newborn screening program employees are at those meetings. They run the meeting. So they're probably the key people that you end up talking with and meeting. So it's just a matter of put yourself out there and meet with people, and then create that communication line. And then you can start saying, hey, can we do this? Information is key. I guess that's the biggest thing, you know, and so they learn the challenges of your disease group. And the thing that I like personally is, you know, I'm not going to just stand up for leukodystrophy diseases. I'm standing up for all the rare disease people that are coming before, because I think that's the role as far as being on that advisory committee. That was the one job I got after I did all that work legislatively, was I was asked to officially be on that. But it's, you know, I think it's very important that the patient voice, whether you're speaking for your own personal patient group or anybody else, I mean, they need a voice on there, and I think that's really the key. So that's what my driving force was. And then as time went on, of course, working into the legislative end of it, finding a senator that's willing to take your disease group moving forward. Fortunately, we got a doctor that was in the legislature, so he was our person that was helped shepherd us through the whole process. So it's a learning process to learn how not only your government works, but then what kind of steps as a patient advocate, you know, what you can do. But patient advocates are key to making this whole process move forward. So I encourage anybody that's watching this to take those steps. And to me, that's the best starting point, and move from there. You can find out who's on the committees through the legislative or through the screening program in your state. So that's where I would begin.
I guess I'm the other advocate, so I will go next. What I would probably say, and I'm just sharing from my own experience as well, is I think it's important to be like really open and flexible, open about where you can find a place to get involved. I started out 3 years ago. I met my state representative, kind of cultivated a relationship with her. I really liked her. I was actually there about privatization of Medicaid. So I was there at the state capitol about something completely different. I was with my daughter. We were talking to her with a group of individuals from the disability community, something completely different. And I just cultivated a relationship with her. And so I met with her for coffee one time. And I started talking to her about newborn screening and my hope of Krabbe disease being added to our newborn screening panel. And so there was an opportunity there that I kind of grabbed onto, and I thought, she wants to, draft a bill. She wants to make this happen. And so I kind of went with it. And unfortunately, the bill never made it to subcommittee, but that's life, right? And partisan situations in the government. And I was discouraged, but through that, like I realized, I kind of really started thinking about the process and thought about, should these people who don't have expertise in this area be the ones deciding if this disease should be on the newborn screening panel? And it really just made me realize that I don't think that. I don't think that's the best way to do it. So I started calling our newborn screening lab. I'm a chemist by training. And so I started asking questions, and I was really interested. I wanted to know what was going on in Iowa, what was like holding us up, why we couldn't add more diseases. And I started learning about the lack of funding for new instrumentation. They also needed more personnel. And I'm like, why can't you adjust the fee? I learned that it's in state statute. It was like, it hasn't been like raised in 10 years. And the rest legislation changed that, which was really exciting. So the lab can now set the fee. But so I started learning like all these things from the lab. And they got me connected with the director of our advisory committee. So I started asking her questions, and I think I bugged her so much, she asked me to be on the advisory committee as a parent advocate. And of course I said yes. But I think that being open, like, okay, there was another opportunity. Okay, maybe I can make a difference here. And then Every Life Foundation wanted to come into Iowa and help that legislation happen. And I thought, here's an opportunity. Maybe I can make a difference here. So I've kind of learned that being like open, kind of having your ear to the ground, being really kind of aware, trying to network, not only with people in your state government, but in people in public health, just trying to find, all those kinds of avenues where you can have an opportunity to make a difference and be flexible. Don't, just say, well, this is what I want to do and this is how I'm going to make a difference. Maybe it isn't, and maybe that won't work. Maybe something else will come. So I think I also want to say, just to not be discouraged. It's really hard to be discouraged. Connect with other newborn screening advocates. If you're a parent advocate, connect with other parents who really are working in the field, in the area. Talking to Lesa was really helpful for me. I also talked with a lot of people from Hunter's Hope Foundation. They were really encouraging. So every time I felt discouraged about it, I reached out to somebody else who did advocacy work, and that really helped. And I think also a really one last thing, maybe the recognition of the way time moves in the newborn screening area is not like normal time. Like everything's so much slower, and just it's so hard to not get frustrated about that, but to just keep plodding on, and don't give up, and just keep fighting. So sorry, I'll get off my soapbox again.
No, what you said was wonderful, and you highlighted a couple of really important things, I think, that I also experienced. And one is, you don't know how much you don't know. It's so easy as a parent who has watched your child go through something terrible and just be like, why can't you just do this? We don't understand. But even last week, when I got to tour the Washington State Newborn Screening Lab, it helped me understand, even all these 7 years later, I'm still learning why they can't just add things. And so it's so important to just go into this knowing that you don't know everything, and that's okay. You have a reason for being there. Your voice matters, and you can take that humility and then learn from the people who understand way more than you do about the inner details of everything. So I think that was excellent advice. Did Amy or Jerry, did you have anything to share?
Yeah, I want to go back to actually something you hinted at. Well, you explicitly stated in your opening statement about how there was an adversarial relationship in the early going with trying to
I should say I felt that way. It doesn't mean it was true.
You're right, actually, I hope. But because I will tell you that nobody who is on a newborn screening committee is there because they want to block newborn screening. They are all strong advocates of newborn screening, and we want to do everything we can to get as many diseases as we can on our screening panels. That said, there are realities in the world, and so one of the roles of the committee is to juggle those realities. Is it really ready? And ready has a bunch of different definitions, but there are actually some pretty formal ones that you can look up that drive newborn screening. I don't think they're going to be as relevant going forward with this ability to move to multiple diseases all at the same time, but it still requires the reality of the committee being able to look at what resources are available in a jurisdiction, a state or a group of states, and try to best match that to what's possible. And if there aren't enough resources, well, that's what there are advocates for, because I guarantee you that I can go in front of a legislator and say, I think this is important. And they look at me and they say, well, of course you do. You want more business. You're a doctor. I already work 80 hours a week. Why do I want more business? The families go in there and suddenly, they're all ears. It's listening to the real life stories of families' lived experience that move legislation forward. And that brings me to my last piece, which is I strongly recommend that people don't advocate legislation for a disease. I think that it subsumes the role that your experts are really trying to take to the best of their ability. What I would rather see is parents go to the legislatures and say, newborn screening saves lives. What about that? Don't you understand? Put money in and fund our screening programs so that they can afford to identify diseases that maybe don't have treatments but look like they're going to have something in the near future, and let's be ready for it. Let's stop the diagnostic odyssey that the parents go through when their kids aren't identified early on. Right now the key, I forget who it was. It might have been you, Bob, who said it. Right now the key is treatment. If there's a treatment, you get it on your board. If it's not, you don't. But in my world, treatment has a different meaning than drug. Treatment is anything you do to help the family. And there are lots of ways that you can help the family by knowing about a disease in a baby that don't involve taking a medication. And we need to be able to think about those at the same time. But all of that demands resources. If we're I'm not going to get political here. If we're putting it, what else is more important than our kids' health? Okay, let's just leave it that way. Why should we put money anywhere else before we have our kids taken care of? And that's the legislation that I would love to see parents and advocacy groups pushing for, because if you go for one disease at a time, you get your disease taken care of, you go home, you feel great. And there are 9,999 other ones that you haven't addressed. That's the latest, 10,000 is the latest estimate of rare diseases in medicine today. So go for I'm not even going to use the word infrastructure. That's wrong. It's get your programs the resources they need to expand to meet the needs of families, and then families define those needs. It's not up to me to define what families want and need. I got my ideas. I am a family, but I know what I would want for, well, now my grandkids. But it's a big step if we can start getting that kind of pressure on our legislators and our legislators, and we'll move the needle way farther than if we do it one disease at a time.
Yeah, I definitely agree that the best use of the legislative process as it pertains to newborn screening is to help garner resources or to help address some of the bureaucratic challenges that I think Carol mentioned in Iowa. It may not be necessarily that they don't have the resources, but it takes 2 years to spend the resources, or something crazy like that. So I think that I agree that that's really important. And I know as well, and this may get to kind of the comment from Effie Parks as well, in terms of there is a lot of discussion right now on kind of, Jerry, what you mentioned, what is treatable? How is treatable different from manageable? How is manageable different from actionable? And how do those all play together? And what makes sense in terms of an opt-out versus an opt-in environment? I think one thing that is hard for newborn screening programs to think through as well, we've alluded to the Wilson and Youngner criteria. So the kind of 10 criteria that diseases typically have needed to meet to be deemed appropriate for population screening. But we also deal with kind of legal doctrines like parens patriae, where we say, like, this is so important that the state is going to take away the family's right to make a decision. And so that's a big, for me, above and beyond the Wilson and Youngner is a big leap. And so that's where I, again, think the resources are really important, because if we're going to say, this is so important that we're going to mandate it, and in many cases, I think that makes a lot of sense, we then have the responsibility to make sure that every family, no matter their circumstances, geography, have access to the treatment, the outcomes, the management, that is ultimately the reason why we added it. And so I think it's tough to make sure that it's all there. And I think those are some of the considerations around why things are still opt out instead of opt in, or opt in instead of opt out, because of that mandated piece adds this additional nuance and responsibility that I think we just have to kind of continue thinking about. Or we're seeing, maybe there is moving forward nationwide a mandated panel and a voluntary panel for a while, and things move back and forth. Again, this just gets back to the need to be creative in our solutions moving forward, knowing that there's a lot of diseases that make sense and are going to make sense moving forward.
Excellent points from all of you. And I know we're getting short on time. So I did just want to say, I do think the states could look at Pennsylvania as a model, because we did fix a lot of these issues revolving around resources. And yes, that was my efforts along with the advisory board, but I truly think that we improved our program and are allowing it to grow. But there is another thing related to Effie Parks's comment about pilots. That is something else that, states have restrictions on. I have actually been wanting for over a year to see if we can change things in Pennsylvania to allow us to do pilot studies like Screen Plus, because as most advocates are aware, like, you have to have pilot data to apply to get on the RUSP. But if states aren't willing to or able to run your pilot, how are you going to get that data? So it's another kind of catch-22. So that is something else that if you wanted to try to make an impact in your state, you could see what that would take. But again, I wouldn't advise just going in legislatively. I would first talk to the people who know, your Department of Health, whoever that may be, because there are certainly ethical considerations with all of this, with legislative mandate. But as we close, we have about 4 minutes left, and I don't think we've had any more questions right now, but that's okay. Does anybody have any final closing encouragements, remarks, anything that you would like to share for advocates who are working hard to add their conditions?
We just keep going, and view your screening boards as your ally, and not your adversary. If you can help us navigate the morass of the public health system, we would greatly appreciate it, I'm the last person to say I know how to do that, and so when Lesa stepped up and said I'm going to figure it out, then that was what I needed to be able to be more effective in my role on the Pennsylvania committee. So I think that it's just critically important for that partnership to strengthen.
That kind of ties into what I'm thinking as well, because when I started, I had no idea where to go. So that was the challenge. And, then I got some guidance, and then moving to the legislative end of things, I met with every legislator in the state, because they were all important, because they all have a vote. So you need to at least create the awareness so they understand what's going on. And I will, honestly say we were in a tight budget. The budget was froze. They weren't hiring people. So when I was doing this, I had some friends that were in the head of, one of them was the head of the budget department. He said, well, good luck. Hopefully you'll do it. And so between him and another buddy of mine that was down there all the time, he says, I can't believe you were able to get this through legislatively. So working hard and working with the right people, and then being in front of those legislators and with your other family members so that they can be your support group, because that's what it takes. And they listen when you start talking about family, as opposed, if you're going in there as a lobbyist, even though technically we are kind of a lobbyist because we're lobbying for our disease to be screened for, but we're not the guy that's got the law office around the corner and I'm standing in there picking on the legislatures every day. So it's people like us that really can make things happen, and that's what I want to encourage everybody. And I'm more than welcome anyone that wants to talk to me about it. And I think this group is a great group of people, and we've got them across the country. And I think they're the best source of information going forward. So I would encourage reaching out to those that have been there and done that, and they can at least try and help you navigate. Each state's different. That's the challenge. So.
Yeah, I guess I would just say that I know even probably listening in on this conversation, it can feel overwhelming. There were a lot of acronyms used, a lot of different groups that we refer to, and newborn screening is complex, and it can be very intimidating when you first join. But I think knowing that advocacy has always been a part of newborn screening. So remembering that we started with PKU, which was wholly advocate driven, from the understanding of the disease to the understanding of the treatment to the creation of the test. So I think just level setting for yourself that you are not stepping into a world where you don't belong. You're stepping into a world that exists because of people like you. So know your place in this and how important it is.
I don't have anything else to add. That was great, Amy.
Well, I just wanted to thank you all again so much for taking time out of your busy schedules to help us equip advocates who want to see their conditions added in each respective state. As a reminder, this has been recorded and we will put this up on our YouTube channel for those who may be watching it later, so you can share it. Feel free to share it. Also, LDNBS.org is a wonderful resource. Yes, I'm biased, but it's a wonderful resource for anybody, especially in the leukodystrophy space. We have come up with all sorts of helpful tools based on our own personal experience as advocates, trying to help you advocate, and we're always willing and helpful. So with that, thank you so much for your time and have a great day.